hand it over to you guys.
Right, shall I start? So my name is Dimitris Tsitsikas. I'm a consultant hematologist here at the Homerton. And I've been here for the last 11 years, believe it or not. I don't, certainly. I will talk for a few things that we will be doing here at the Homerton. Some are in conjunction with the Royal London and Queen's, some are just at the Homerton. And that's pretty much it.
And sitting beside Dimitris, Paul Greaves. I work at Queen's at BHRUT, which also looks after King George Hospital. I work with Poppy, who's just introduced herself, Abbas, the other two consultants looking after sickle cell. And we have an ambition to be able to open clinical trials at Queen's and recruit patients. But for now, we're reliant on the likes of Dimitris and colleagues at the Royal London to enable access for the patients further out in Essex to these trials. I've been working in sickle cell as a consultant for the last 5 or 6 years, all of it at Queen's. So excited to hear about what's planned.
Okay, right, shall I kick off then? Yeah. Right, so I just put some slides together. They're more of talking points rather than detailed explanation of what everything is. It's just to say what is happening, what will be happening, and then there's some really exciting stuff, and it's quite exciting times in sickle cell in general, because after a very long period of time where nothing was really happening, we've had hydroxyurea and transfusions as the only treatments for sickle cell disease for decades. And over the last few years, we have new agents coming out. We have new drugs, we have new procedures, we have new indications for old procedures. Of course, we have the prospects of transplantation and gene therapy, and I'm sure that Prof. Telfer will say more about it. But in my view, the really exciting thing is the fact that we see new treatments coming out, and there are a lot more in the pipeline. So what I will do is I will talk about, if you can move the slide, Hazel, please. Just don't do the up here, just get them all up.
Okay, so you want
Yeah, because otherwise it's going to be change. So we have two commercial studies at the Homerton on new anti-sickling agents. One is a ferroportin inhibitor, and that is open, and I will talk to you about it. And there is an anti-E selecting monoclonal antibody, which is not open yet. We're not sure whether we will take part, but we probably will. I'm not going to say much about that, but it's something that may be coming. Most of you probably know of crizanlizumab. So that is a similar drug. And then we have two investigator-initiated studies. One is called EPOCH-4, where it's more a qualitative study about patient experience, patient perceptions, about the experience of patients in hospital, about the perceptions and the understanding of sickle cell among staff. So it's more to do with patient interviews, and again, I'll tell you more about it. And the other study we have, and we will be starting soon. It's about using plasma exchange after red cell exchange for the acute chest syndrome. Now, you will notice that is in bold letters, and there is a very simple reason for that. That's my baby. I'm really excited about that. It's something I really look forward to start doing. We have used therapeutic plasma exchange, and I'll tell you more about it, on several occasions and with great results for different indications in sickle cell disease. And and this work has been actually replicated in many parts of the world where we work together, and we have seen some great results. So I'm really excited about that, and I'll talk to you about that more. So can we change? So the first drug, the study about the new drug I talked about, that is already open, is a ferroportin inhibitor. So ferroportin is the receptor in your gut that helps transfer the iron from your food into your circulation. So helps you absorb your iron. So if you inhibit, if you stop ferroportin from working to some extent, it means you absorb less iron and you induce a degree of iron deficiency. Now, I know that most people think that iron deficiency causes anemia, and of course that's true. And you say, and you think, why would I have anemia already and want to have iron deficiency as well? Sickle cell disease anemia is not because of iron deficiency, it's because the red cells are abnormal and they break down. It has been known for a very long time that a degree of iron deficiency is actually beneficial in sickle cell disease, because what happens when a patient with sickle cell disease is iron deficient, not profoundly, but has a degree of iron deficiency, the sickle hemoglobin within the cell is more dilute, and that makes it less likely to actually sickle, to actually become rigid and give the red cell that abnormal shape. So this agent is supposed to induce a degree of iron deficiency. The preclinical studies on it have shown it to be quite safe and effective, but whether it is or not is what the study is about. And at the moment, at least as far as the Homerton is concerned, I'm going through all patients. I'm making a list of all patients who would be eligible for it. And all of you who are eligible for it will be getting a letter from us and subsequent a telephone call from me to discuss whether you have any questions and whether you are interested at all. This is a study I would be very keen to have it open to other centers as well who do not offer it. So Queens, I know, are not taking part in this study, and I have spoken with Paul and Abbas, and I know they will be sending patients who are interested because they can be treated here on the study. The Royal London, I'm not sure whether they're taking part or not. Needless to say that if they're not, patients from the Royal London are more than welcome. And generally, patients in our geographical area, even if they're not at the Homerton, would have access to this study. It appears to be quite safe. As I said, it appears to be effective. And one benefit, one of the many benefits of taking part in the study is that the ones who do take part, if it shows to be effective, they will have access to the drug after the study is over. It goes on for 4 months, so it's not a particularly long study, but they will have access if they wish to for another 2 years. So that is a big plus. I'm not going to say anything more because I will be sending the full patient information sheets out to all eligible patients at the Homerton, and feel free to always get in touch if you want more information. I'm not saying anything about the other drug because, as I said, I'm not entirely sure whether we will be taking part in it, even though most likely we will. The selectins are a group of molecules that line the inside of the blood vessels, and that's where the red cells and the white cells stick in a way, and that enhances that process of sickling and blockage of the circulation that causes crisis. As I said, crizanlizumab, for those who know, which has been around for a year or two, is of the same class. So an anti-E selecting monoclonal antibody essentially is expected to make blood less sticky, for lack of a better description. But I'm not going to say more because, as I said, we're not entirely sure we'll be part of it. I'll talk about the EPOCH 4 study. I'll tell you what I know because it's not something I'm particularly involved. Well, I am, but I'm not the one running it. It's the PhD of one of our registrars at the Northeast London rotation, Stephen Hibbs. And it's a qualitative study, and it is about, again, exploring the patient's experiences from their illness, from the healthcare, from healthcare services, also exploring the attitudes and the understanding of the condition by healthcare professionals, be it nurses, be it doctors, and so on, creating focus groups where all get together and discuss. And it's not the typical study where you have percentages and numbers and so on. It's qualitative, so it's about creating a narrative as to what is the interaction, if you like, what are the expectations, what's the understanding, what's the perception of the condition, both by patients and staff, to help us bridge that gap between healthcare professionals and patients, which is quite often, as I'm sure you all know, a big issue. It's a very big issue for us, the patients. I can tell you it's a very big issue for us, the doctors, because in our hospitals quite often we as well are treated in a way as if, how should I say, treat a condition that is not as severe as we know it is. Let's put it that way. So that's the work that Steve is doing, and that will involve interviews with patients who are willing to take part. So he will be getting in touch with many of you. Let's move on. And we come to the bold letters. So this is sequential red cell exchange and therapeutic plasma exchange for management of the acute chest syndrome in sickle cell disease. So essentially, you all know about the acute chest syndrome. Can we move one slide, please? So the acute chest syndrome is a very severe complication of sickle cell disease. It is the second most common cause for coming to hospital after a plain painful crisis. It is potentially life-threatening, but also can cause long-term problems with the lungs and the heart and so on. Any patient is at risk, whether SS or SC. The SS patients are more at risk, but the SC are also at risk. And the mechanism that causes acute chest is not one thing, it's many things. If we put the next slide, I'm just gonna, I try not to be too technical, but you have to think the acute chest syndrome as a vicious circle where you have areas of the lung where there is low levels of oxygen, there is inflammation, there is a lot of acidity, and that causes the red cells to sickle, which cause the blood vessels within the small blood vessels in the lungs to block essentially, which in turn makes the lack of oxygen and the inflammation and the acidosis worse, and so on and so forth. And there are some external factors that feed into that circle. And the more important ones are the hypoventilation. So that means that you don't take deep breaths, and that's usually when you have a painful crisis that affects your chest wall and you cannot take a deep breath because it hurts. And on the other hand is fat emboli. So quite often what happens, especially in the adult population, there is bone marrow necrosis. So the circulation in the bone marrow stops. There is temporary death, let's say, of the bone marrow, and that releases fat in the circulation, which on one hand goes and blocks small vessels in different organs, but also creates many inflammatory substances that are very toxic. And those are very damaging as well, probably more damaging than the blockage itself. If we can move on. So therapeutic plasma exchange, what is it? So what is plasma, first of all? For those of you who don't know, so plasma is the blood. If you were to take away the cells, the white cells, the red cells, the platelets. So if you think of blood as a solution, where the main ingredients are the cells, the red cells, the white cells, the platelets, the plasma is the liquid where all those cells circulate. Within the plasma is all the other substances, the proteins, the vitamins, the enzymes, everything. And therapeutic plasma exchange is removing the plasma selectively of a patient and replacing it with donor plasma, normal plasma. It's the same procedure exactly and the same equipment as the red cell exchange transfusions, the automated red cell exchange transfusions. And those of you who are on regular red cell exchange transfusions know the equipment and the procedure. It's exactly the same. It's just instead of removing red cells and replacing them with normal, we remove the plasma and remove it with normal. It's exactly the same. It's a safe procedure. It's widely used in other areas of hematology, but is also used in many neurological conditions, many rheumatological conditions. So even though it's not widely, it has been used in sickle cell before. We have experience with it as well. But it's certainly quite well established in other areas. Next slide, please. So the plasma of patients, why do we do it? Why do we think about it? So the plasma of patients with sickle cell disease contains many pro-inflammatory cytokines. So that these are molecules that cause inflammation, widespread inflammation. I put the red cell autophagic material. What is that? So as the sickle red cell breaks down and bits of the cell get eaten away, the membrane of the cell gets reversed, and on that surface, on that reverse surface, there are lipids that can create more inflammation and more thrombosis, more clots. They have other procoagulant factors, so substances that can cause clots in your legs and your lungs and so on. Sorry? Okay. They contain the plasma contains free hemoglobin, because as the red cells break down, hemoglobin gets released in the circulation. And the hemoglobin, when it's free, it binds and destroys in a way something called nitric oxide. And the nitric oxide is very important so that the blood vessels are of the right caliber and they don't get too narrow. And it does contain adhesion molecules. So these adhesion molecules are molecules that make the blood more sticky. Remember how I said that part of the sickling process and the crisis is the stickiness of the blood on the walls of the blood vessels. So these adhesion molecules are contained in the plasma. And all the combination of all these substances enhance pain, cause pain. They enhance red cell sickling, hence crisis and vasoocclusion. Nitric oxide depletion, as I said, you lose nitric oxide, which helps the blood vessels keep their normal size as a result of the free hemoglobin in the blood. And they cause direct tissue toxicity, and there are many areas of evidence to show that these substances do cause direct toxicity, especially in lungs and kidneys. So the rationale of using therapeutic plasma exchange in sickle cell disease is that sickle cell disease is an inflammatory condition, really, and there is a high peri-inflammatory, so extremely inflammatory component during many sickle cell complications. So, and I already said that these pro-inflammatory cytokines, these molecules that cause inflammation, can be very toxic and very damaging. So adding plasma exchange to red cell exchange transfusion can actually improve both the outcomes, both immediately of an acute complication and long-term effects. It can be an alternative to red cell exchange for patients who cannot be transfused with red cells, possibly because they have too many antibodies. And as I said, it's a safe procedure and it has been previously used in sickle cell. Next slide, please. I'll just show you a couple of cases, a couple of things that we have done here because we have used it on many occasions. This is a case of a 30-year-old man with homozygous disease who had many crises, and eventually we put him on regular transfusions. Unfortunately, after the first one, he had a very severe transfusion reaction, something we call hyperhemolysis, which meant that he could not have any more transfusions. And then he was admitted one day with very severe pain. We could not get on top of his pain on the wards, and he had to go to intensive care just to get more strong analgesia safely. And then his liver function has started deteriorating. It was getting worse and worse. And what he had was something we call intrahepatic cholestasis. So it means that the bile was trapped within his liver, and that would lead eventually to liver failure. Now, what you do in a situation like that is immediately a red cell exchange transfusion. But in his case, with the previous severe reaction, if we did, it would be very likely fatal for him. It would be very severe. So it was something we really wanted to avoid. So we had decided to do a plasma exchange just to remove the excess toxins in his blood and hopefully help things settle down without knowing whether it would work or not. If we move the next slide, please. So not only it worked before that, so not only it worked impressively fast. And the first thing that happened was that his pain got a lot better immediately. As I said, he had very severe pain. We could not get on top of it. And that's why he had to go to intensive care to begin with. Even in intensive care with heavy opiates, again, he was in a lot of pain. The moment we started doing the plasma exchange, he got better. The first graph you can see is his bilirubin. So that, for those who don't know, is that substance that make your yellow, that make your eyes yellow, that give you jaundice. And it was extremely high. And you can see that after the second procedure, it keeps coming down and it stays down. The next slide is ferritin. And ferritin is a substance that is produced by the liver. It stores iron, but also it's a very good marker of inflammation. So with ferritin, and his ferritin was sky high. So you can see that it was in the many thousands, when normally it should be more than 250 or 500, that kind of thing. And you can see that even after the first procedure, we did 5 procedures, even after the first one, it comes down very sharply and it stays down. And the man was discharged 6 days later, and he was absolutely fine after that. And that was in the context of a very severe complication, which was really life-threatening. Next slide, please. Another thing I want to talk about is something called fat embolism syndrome, where what you have is extensive bone marrow necrosis and release of fat, as I was talking about earlier, which causes one blockage of the small blood vessels of the fat droplets that are released in the circulation go and block the small blood vessels. So that's one effect of this complication. But also this fat gets transformed into inflammatory substances that are very toxic themselves. And we have a special interest here at the Homerton in this complication. We have done quite a lot of work on it. And it's a very, very severe complication. It's very interesting because it affects predominantly patients who have SC disease or S beta plus, those who are quite mildly affected by their sickle cell disease. It has, unfortunately, very high mortality. About 1 in 4 patients, even now, who develop it die. And from the ones who survive, about half are left with severe neurological impairment, cognitive impairment. There is a lot more we need to do to deal with this complication, which we consider rare, but actually is not as rare as we may think. The standard treatment is an immediate red cell exchange transfusion, and that is life-saving. But as I said, even when someone's life is saved, there is a very high likelihood that they are left with severe consequences neurologically, with their cognition, their mental status, as well as being able to move and so on. So we have been advocating since 2019. We worked with some colleagues from the States who also have an interest in fat embolism syndrome. And we did suggest, and we tried to think of other ways of treating this complication. One thing we thought was to, after a red cell exchange, follow with plasma exchange with a view to remove, because what you do with plasma exchange is you physically remove the fat from the circulation, as well as these toxic substances. And we have done a couple here. Actually, we have now done 4 here. And we have been in communication with many other colleagues around the world who, as I said, we have an interest in this, and they get in touch with us. And now we know, this is a slide from a talk I gave to Madrid a few months ago. Actually, we have more. So we compared cases of fat embolism published in the 10 years between 2012 and 2022. We could find 39 cases that they were treated with red cell exchange alone. And there were 13 cases at that time where there was red cell exchange followed by therapeutic plasma exchange. And you can see from the chart next to it, the blue bars are the patients who only had red cell exchange. The red bars are the ones who had red cell exchange first and then plasma exchange. And you can see that when it comes to death, the death rate is less than half of what it is with red cell exchange alone. When it comes to severe neurological problems for the survivors, you can see that about a third of patients who had red cell exchange did suffer severe neurological consequences. And there were no patients treated with red cell and plasma exchange who were left with neurological problems. When it comes to mild neurological problems, there were some on both sides. The ones with the plasma exchange, I can tell you that they are all actually relatively recent cases, and most likely those patients who have some mild neurological impairment, for example, some weakness in a leg or something like that, most likely eventually will make a full recovery. And at the end, you can see the proportion of patients who made a full recovery. And you can see the huge difference where with red cell exchange alone, it's about 1 in 3 patients makes full recovery. With red cell exchange and therapeutic plasma exchange is more than 70%. And I can tell you, I have not updated the slide. I gave this talk 2 or 3 months ago. Since then, there have been 2 more cases published where plasma exchange was used. Again, so instead of 13 cases that I have on the slide, we have 15 cases worldwide that we know of where plasma exchange was used. And again, those 2 patients made full recovery. So what we talk about is even less mortality, even more complete recovery compared to red cell exchange alone. And if you think of the acute chest syndrome, if you think of fat embolism syndrome, acute chest syndrome is part of fat embolism syndrome. So you can think of it, even though it's not exactly like that, as an extreme case of acute chest syndrome. So there is a rationale behind using plasma exchange. Next slide, please. I think we're spending too much time, so I'm going to quickly run through this. So the objectives, the reason why we do this study is to see whether we can do it, because it does require expertise, equipment, nurses, training, and so on. We need to see whether we can do it. We want to see how it would work, what infrastructure we need to have. We need to see what doctors, nurses, and patients think about it. We want to see, and what we want to do is measure these toxic substances before and after the red cell exchange transfusion, and then before and after the plasma exchange transfusion, to show that they are, 1, very high as expected, and 2, that plasma exchange makes a difference. Next slide, please. And then the secondary objectives, which means information we get as we go along looking for the primary objectives, is we want to do a systematic review of the literature about the use of plasma exchange in sickle cell disease. Get, again, as I said, patients and clinicians' views of how should we design a second study, a big study, because this is a small feasibility study. So this is a study, a small study to see whether we can do it. And then we want to follow that with a big clinical study where we want to show and prove that giving plasma exchange is superior to just giving plasma exchange, to just giving red cell exchange alone. And of course, assess the safety of the procedure. Next slide, please. And when it comes to so what we want to do is Homerton, the Royal London, and BHR Queens were combined. We have more than 1,000 patients, adult patients, and we have a modest 15 cases of the acute chest syndrome per year, severe enough to require an exchange transfusion. So we want to and what we will be doing is take samples before and after the red cell exchange to measure all those toxic factors I talked about. And then we will be measuring them again before and after plasma exchange and 48 hours after plasma exchange to see whether that reduction is sustained. We want to get 15 episodes in the space of 18 months. The first 5 we will treat as standard with just red cell exchange, and we use those patients as controls. That is the standard of care. That is how we treat patients now. And then the next 10 episodes we will treat with plasma exchange, with red cell exchange first, followed by plasma exchange. And we'll compare and we'll try and we'll see whether it makes a difference. And as I said, the idea is that if we see that it does make a difference, or that there is a suggestion that it makes a difference, we design a larger clinical study where the primary outcome is not to just look at whether these toxic substances reduce, but to actually see whether we make people better by doing so. Next slide. So the primary outcomes, primary outcomes are the outcomes that we mainly look at, and we want to see a statistical significant difference. Is the before and after plasma exchange levels of the selected biomarkers, and also the safety of the procedure, make sure that it is safe. And the secondary outcomes, and by secondary outcomes in a clinical study, we refer to things, to information that becomes available, even though the study is not designed to prove those parameters, are things that is information that we collect and gives us an idea of whether there is a point in designing a study that is designed in a way to prove statistically those factors. So the secondary outcomes will be reduction in pain, as the patients reported on a scale from 1 to 10. The need for non-invasive ventilation in intensive care or intubation. The number of days requiring mechanical ventilation for those who do. How long people stay in the intensive care, how long they stay in hospital. And then we will be checking the echocardiograms and the lung function sometime after the procedure, because, as I said, the acute chest syndrome can have long-term side effects affecting the lungs and the heart. And we want to see if there is any suggestion that adding plasma exchange to red cell exchange after when someone has the acute chest syndrome has a benefit in the function of those organs. Next slide says, thank you very much. And if you have any questions, I will be very happy to answer if I can.
Thank you, Doctor. I was just wondering, it's Shane here, by the way.
Hello.
Hi. So with the fat embolism syndrome, is that something that perhaps can be predicted in regards to blood count, or is just random like chest syndrome?
It doesn't. It cannot be predicted. There are two very interesting things about it. As I said, it's a paradoxical thing, because it's probably the most severe complication of sickle cell disease, but it affects patients who are who have the most mild forms of the disease. So they are the patients who never go to hospital, who never get crisis, who never had the acute chest before, who don't have kidney problems. They're absolutely fine. Then one day they develop pain of unusual severity. They describe it as, and if you go through all the cases that have been published in the literature, it's like the same patient with different faces. It's identical stories. Suddenly they develop pain that they have never experienced before. They go to hospital, and within 24 hours, they develop multi-organ failure. And if you don't act very fast, if you don't recognize it and act very fast, they die. They die. There is nothing to predict that. You only have that patient profile. And there is also a suggestion that there is association with a virus called parvovirus B19, something that causes a plastic crisis in sickle cell disease. But it's a very common virus. It affects sickle patients and the normal population. But other than that, there is nothing to suggest to predict it.
Okay. All right. Thank you for your time, Doctor.
Nice hearing you.
You too.
We've got a question in the chat from Kai, who says, what countries are currently doing RCE plus CPE?
So what? There have been quite a few centers that we have spoken to, and they have done it in the context of fat embolism in Britain. So we had a patient from Queens recently who did very well. We had a case in Manchester and a case in Liverpool, and then we had one case in the US. We had two cases from Toronto in Canada. We had a case in Denmark. There was a 13-year-old girl, and it's pediatrics as well. The cases in Canada were both pediatric. The girl in Denmark, in Copenhagen, was pediatric, and she was in a dreadful state. We had a Teams meeting. She was on ECMO, which is one step up from mechanical ventilation. It's when someone is in very severe respiratory failure and they don't respond to anything. And they were about to pull out, but they did plasma exchange, and the girl now is absolutely fine. Unfortunately, she suffered an extensive clot that had nothing to do with the plasma exchange. It had to do with the ECMO, and she had to have a leg amputated, which is terrible. It's tragic, but she has a prosthesis and she's back horseback riding. So a very positive outcome on a girl that was otherwise in effect dead. I also can tell you that my colleagues in the States that we had worked before have done quite a few themselves, and for them, as for us here at the Homerton, following plasma exchange, following red cell exchange with plasma exchange is standard of care. It's not, we don't do it ad hoc, we do it as standard of care. The thing with plasma exchange is, one, it makes sense. If when you have a fire, if the fire can kill you, the flames can kill you, but also the smoke can kill you. And most often it's the smoke that kills rather than the fire itself. Equally, when you have an acute complication that causes a shower of toxic substances that we know are toxic to tissues, there's no point doing just a red cell exchange, which deals with the fire in a way. Did we lose connection?
No, we're still connected.
Okay.
We can hear you.
Okay, so in the same way, where you do a red cell exchange, to use that analogy between fire and smoke and so on, with the red cell exchange, you put out the fire. With a plasma exchange, you clear the smoke. And as I said, at the same time, it's very important to bear in mind that it is a safe procedure. It's something that has been used in sickle cell disease, but not that much. But it's very widely used in other hematological situations and in other specialities. So there is a lot of experience with it.
Can I ask you some very quick fire questions?
Of course.
I know you've got limited time. This is Kai. And the quickfire questions are, when was it first done?
We did the first one in 2014.
2014.
Then we didn't do any, and the patient made a complete recovery. She's very well, and we see her.
No, that's good. I'll go on to the next ones. That's fine. That's a good answer. Then 5 years when you're testing lung function, heart function, all sorts. What's the 5-year study looking like on those patients?
We haven't tested lung function or anything because the patient has been so well that we saw no reason. We don't test someone unless they have any kind of symptoms. The patient has been so well since then that we haven't done it. And it was not part of a study, it was more of a desperate measure.
Is it expensive?
To perform the procedure.
The RCTP, is it expensive to do the procedure? Yeah.
It's reasonably expensive, but don't worry, you will not have to pay for it.
And do you have it just once if you're very unwell, or do you need it a number of times?
That is a very good question. And the answer is we don't know. I don't think you can put a number. Of all the cases that we have done, some we have done just one. We have the last one we did 10. It's part of what we will be studying, whether we can establish how many we have to do. I suspect that there's not going to be a fixed number. And what we will be doing is we will be monitoring the clinical response of the patient, as well as the different blood tests that show us how this hyperinflammatory state is going, that will make us decide to carry on or stop.
Penultimate question, how many approvals are there for FDA, EMA? Does it have any approvals as yet, or is it early stages?
It's early stage. We are just finished the protocol, but we do have funding for it. We are designing the application for ethics, which I'm pretty sure we will get because it is a very safe procedure. So it's not a new drug, if you know what I mean. It's a procedure that is widely used in medicine, just not in sickle cell so much. So we will get ethics. We hope that we will be able to start before the end of the year.
And finally, the hyperacute unit, is it would it be possible, subject to passing all approvals, that hyperacute units around the country might have staff trained to do this, offer this treatment?
That opens the topic of the hyperacute unit. I don't know what that is. The problem is that many colleagues of mine don't know what that is. And the even bigger problem is that many of the people who have designed it don't have a good idea what it is. I will say that all specialist centers for treating sickle cell disease will have their staff trained to perform this procedure, which is actually anyone who can do red cell exchange. The plasma exchange is even simpler. It's exactly the same equipment. It's exactly the same process. It's actually, if anything, a bit faster.
Yeah. I'll hand over to others. Thank you very much.
It's a great pleasure. I have 5 minutes before my taxi arrives. I'm like the Cinderella. so my carriage will become a pumpkin in 5 minutes.
I have more questions, but I'm going to let others ask.
No, go on. I can roll it.
I have a quick question. So people who are currently on red cell exchange, are they going to also now start receiving plasma exchange as well, or is this something?
Not at the moment. It is something that I cannot exclude in the future, because one thing we saw, even though that was not the purpose, we saw that whenever we used it for different indications, the first thing that responds is actually pain. So I don't I cannot, what I want to talk about is the study, which is going to be a formal study with ethics approval and everything sorted for the acute chest. But I can very easily see plasma exchange being used a lot more widely in the management of different complications of sickle cell, be it pain, be it leg ulcers. I think there is a very good reason why it would be effective in leg ulcers, but or pain itself. But for the time being, it's just the acute chest syndrome, just 15 patients across the 3 sites, and we'll see how it goes.
Thank you. And one quick question. Well, could the plasma help reduce or prevent necrosis? Because I notice a lot of sickle patients get avascular necrosis, and that's something that just comes with the territory.
I don't know. I don't know. I don't want to give you an answer to that because I really don't know. I think there is I think we leave it at that. I think there is a very good reason to think of plasma exchange in sickle cell disease because the plasma of patients with sickle cell does contain a lot of toxic products. And we focus on the red cell because it's iconic. It's the one that has an abnormal shape. It makes very good logos. The red cell that looks like a crescent. But we forget that the plasma of patients with sickle cell disease does contain very, very harmful substances.
Thank you. Thank you so much.
Sorry, are all the 15 patients, they all adults, or is it a mixture of adults?
It's just adults. It's just adults.
Will it be offered to children or just adults?
Sorry?
Will it be offered to children in pediatrics, so they're just?
What we are doing is just a feasibility study, which means it's a study that the first thing we want to see is, can we do it? Because there are many things that we can think that make sense and they're great, and they may be, but it turns out that you cannot do them for different reasons. So this is a feasibility study, a small number of patients to prove the principle that you can do it, that it is safe, and that you actually do reduce, to prove that you do have these very high levels of toxic substances in the blood, and that you do reduce them significantly by adding plasma exchange. With a view to go further and do a large clinical study where now you look at purely clinical outcomes. Do patients do better? Do they live long? Do they survive better? Do they have less after effects?
Thank you very much, Dr. Dimitri.
Pleasure.
Thank you so much.
It was a pleasure.
Thank you for bringing your doctor as well. So good.
If I had left her alone at home, I think social services would be knocking on my door. Right. I shall leave you all. Very nice talking to all of you.
Thank you.
And have a very good
Thank you, Doctor. Very informative.
Bye.
Thank you.
I just want to let you guys know as well that Professor Telfer even has actually joined us. So, Professor, if you want to say a quick hello. I know everyone here already knows who you are, but why don't you?
Can you see me? Oh, hi there.
Hello.
Hello, everyone. I'm sorry I was a little bit late to the meeting, but I think that I'd just like to say that this presentation from Demetrius was really good, and I think it's a very important topic, and that we're going to be certainly working with Dr. Demetrius in trying to investigate further and in the use of the plasma exchange. So
Thank you. I don't know if anyone else has any questions for either Professor Telfer and Dr. Paul Greaves. I mean, Dr. Paul Greaves is actually still here.
I can't see. Yeah, all the way
That's the
over.
thing.
Yeah.
He's here. Too close, that's terrifying.
I would ask if it's commonly used in the NHS. I mean, I hate to ask, why is it not already used for sickle cell patients? And I mean, my daughter has exchange transfusions, and if it's already a mechanism in the system, I know Dr. Trevincius said he doesn't know, but what do you think the likelihood is that it might be rolled out? Because if it produces such good results, you would think it makes sense to, especially people that may, I know they not, even if you have an exchange, it doesn't mean you would suffer from chest crisis. But I mean, what do you think the feasibility of it possibly being extended to people that are already on exchange, for example?
Do you want to answer that, Paul?
I could give it a go, but I think we've got to prove that this is different to what we do at the moment. And even though looking back over everything that's been published, the problem with looking back over things that have been published, there's a risk that people only publish when they've had a success story. And we've heard all of Demetrius and colleagues' success stories here. And there's enough evidence now in really sick people who would otherwise die to use something which is quite new. And I think if we can prove that it works in this very sick patient population, then we might be able to justify, because even though it's quite safe, it still involves exposing someone to extra blood products. And the plasma itself can come with infusion reactions. There's all sorts of potential risks. So we have to first show it in the most sick, who seem to have the most, the least direction to go, the least options, like that young woman in Denmark that spoke about, like the patient we've had at Queen's and transferred across, and see that it seems to work. Then prove that it works by comparing two, which is what this study will show. And then if that's shown to be plausible and safe and effective, then we can think of other things like avascular necrosis, like people who have a stroke, like people who've got leg ulcers, and see if it can add benefit to exchange transfusion, which we know we can do safely and we know works, but we know it doesn't work for everyone.
Yeah, I agree with what you're saying, Paul. I think it's certainly something that has been around in the health service for many years, but it hasn't been fully evaluated in sickle cell, and perhaps we've been a bit slow in doing that. But it's partly because it does involve blood products. You need very good venous access. You need to put in long lines to do it, and so it's understandable that it's being evaluated at the moment just in the most extreme situations. But I think it's quite interesting what Dr. Demetrius was saying about the patient whose pain settled soon after starting the exchange. And I think you'd have to evaluate that in quite a lot of other patients to see whether that is true. But one of the things that we don't actually have, we don't have many treatments for sickle cell, but we certainly don't have a treatment which can suddenly stop a pain crisis once it's started. And there have been quite a lot of drugs that have been developed by drug companies to try to do that, and they've all failed. So possibly, I mean, it's very, very early at the moment, but let's see how things go.
We've got two new questions in the chat. Cheryl kind of wanted to know, so I think this is more directed at you, Professor Telfer. Cheryl wanted to know if, like, about the what's being done for future therapeutic cures for sickle cell.
Say that again, Hazel.
So Cheryl
Yeah.
asked
Hi,
about
Cheryl.
viable in Royal London, what's basically viable now and what's being done in the future for therapeutic cures.
Okay. Yeah, that's a Okay, it would take a little time to answer that. And I think we have discussed some of these new treatments in other meetings. So I'll just do a very brief summary. We have a small number of options that are actually available for us at the moment. And most of these are to help to keep you healthy, or at least to help to prevent the onset of episodes of pain. So we have hydroxyurea, regular transfusion, which can be simple, or exchange transfusion. There are one or two treatments that have been evaluated in clinical studies and have shown some promise, but these treatments I'm talking about are not yet available in our health system for widespread use. And there are some problems with their further development. So one of them is this drug called prizanizumab, which is actually a biologic therapy which inhibits adhesion of red cells and platelets and white cells to the blood vessel wall, and is thought to have some effect in reducing the kind of obstruction of the blood vessels, what we call vaso-occlusion. And so in a kind of an early access scheme, we've been able to offer this for people with crises. And the aim of the treatment is to reduce the frequency of the episodes. So some people, I'm sure, on this call are actually taking it. We do have a problem now because the large clinical study done in several centres around the world, what we call a phase 3 study, comparing with placebo, that's a non-active dummy drug, didn't show a benefit in the way that the study was analysed. So there's been a question mark about whether this is going to progress into clinical use in the UK. We don't know yet. The second drug is voxelotor, which is something you take by mouth, and it's a small molecule that basically binds to hemoglobin inside the red blood cell and stops the hemoglobin from undergoing the sickling. And in the clinical trials that have been done, there's been a positive effect in improving the anemia, but not in improving crises. So people taking voxelotor have a rise in their hemoglobin level, but quite a few of them continue to have pain episodes, and sometimes even worse pain episodes. So that's recently been evaluated by what we call NICE, which is the authority that makes decisions for the NHS about new drugs and whether they're going to be funded. And we don't know the result of the appeal just yet, although that should be coming out very, very soon. But the initial response was negative because there wasn't really enough evidence that it had a long-term clinical benefit. So these are a little bit disappointing with these new treatments. However, there is a pipeline of new drugs that are coming along and that are in clinical trial at the moment. And I would say there's probably about 5 or 6 quite promising new drugs that, and hopefully at least one of them will make it. Some of those studies we're involved with. I think, Paul, you might be involved with 1 or 2 of them at Queen's as well, and at Homerton. And I think just as a general thing, I would encourage people to participate in clinical trials. It's a altruistic activity in making the possibility of new treatments available, not only for yourself, but for others living with sickle cell. And the only way to develop better treatment is by kind of helping with these clinical trials. So there are a number, and we get approached about new drugs quite frequently to participate in clinical trials. And sometimes we can't do them because we don't have the resources, but we try to do as many as we can. So there's the new drugs, and then of course there's the gene therapy that is looking very promising. I think that's probably the subject of another talk. because there's quite a lot to talk about with that. But, and again, that is not yet licensed, but is going through the regulatory processes at the moment. There's still evidence from the clinical trials that needs to be had, but the results so far with the Vertex gene editing clinical trial are looking quite promising. And then other ways of doing bone marrow transplantation or stem cell transplantation, but in particular using an unrelated, sorry, not an unrelated, a half-matched donor. So that's what we call a haplo donor, which might be a parent or a sibling who's only half-matched. And there is a trial that's just starting in the UK. You might have been along to the trial launch meeting at Guy's Hospital about 2 months ago. That's called the Redress trial. And that's looking to see whether this form of transplant might be an option for people with severe sickle cell as a potential way of curing. But it would involve a very complicated and potentially risky transplant procedure. So those are a few of the, and probably the main kind of treatments in development at the moment. Cheryl, I don't know whether that answers your question.
Yeah, that's great. Thank you, Dr. Telfer. It's quite a lot to
There's quite a
think
lot.
about,
And yeah,
especially with the last two.
Yeah. So I think there's it's encouraging that there's quite a lot of activity and quite a lot of potential new drugs, but it's not proving easy to find a magic bullet, if you like.
Yeah, yeah. Thank you.
I'm interested to hear more about the gene editing option and how likely is that to become a real option for most people, and what's the main difference between that as in side effects or dangers versus bone marrow stem cell transplant, please?
Yeah.
We can definitely do like a session, like a talk on that, like an extensive talk on that, because I think that, yeah, a lot of
I think that might be, I mean, it's probably best to have a separate, I mean, I'm very happy, and maybe Paul or Demetrius could also do this, but I'd be very happy to do a kind of focused session on that, because there's quite a lot to talk about, and I think it might not be doing justice.
Yeah, I think if
in the meeting today.
Sorry, Leander here. If people have got ideas of what they want to be covered, you can either put it in the chat or you can put it in the Solace group, and then we can try and make I don't know, a thing, an agenda, not an agenda, but like a timetable of when we talk about what, because we have this room forever now. So you know, every third Tuesday of the month we're here. So we don't need to try and rush everything in one session. Yeah. And I absolutely don't want us to do that. So yes, if you've got other things or even the same thing you want to talk a little bit more about, then let us know.
Yeah. And now that we've had talks from Demetrius, we've seen Dr. Paul Greaves, and obviously we know Professor Telfer. We all know you, so now you'll be invited back.
I've been delighted, looking forward to it.
So, yeah.
Okay, well, thank you so much anyway.
You're welcome. There's another list.
Yeah, we've also got Becky, who's put in the chat, will the other trusts perform the RSET, then transfer to Homerton for the TPE, or will both procedures happen at Homerton? Question from Michelle.
So I'll speak for BHRUT because this arises from my own trust, and there might be a hidden message in this, I think, in the sense that I think if we're participating in this trial and we see this as a future for the emergency management of people with sickle cell having a crisis, we've got to have those that are trained in RSET also trained in therapies of plasma exchange. It's the same machinery. It uses the transfusion lab in a slightly different way. It uses settings slightly differently, obviously the specific training, but it's a very transferable skill. So I see no reason why anyone who's able to do it can't deliver it. But once again, it's always about the resource. because if we're expanding and making more prolonged an emergency service, we've also got to acknowledge that we're taking nurses away from an elective service, meaning the regular planned exchanges, and that's about building and expanding the service to accommodate all of this, and that requires planning. So we can't overpromise, but we have to offer equity across the region. And as you all know, access to exchange transfusions is one of the things that have been focused on by the all-party parliamentary report as being inequity in sickle cell different to other diseases. So I think this plays very helpfully for us into the narrative that we need a better resource to provide specific care.
Yeah.
But in brief, I would expect us to be able to deliver therapeutic plasma exchange on site at BHRUT, and I'm sure Dr. Telfer will say this.
Yeah.
Amazing.
Definitely.
I mean, Mary's also put in the chat that like she missed the beginning, but like she knows that certain therapies are being taken away from us. You mentioned earlier that crizolizumab is on the fence about being taken away from us. Are there going to be any more holistic approaches that will be being brought in to help sickle cell patients?
Maybe I can answer that, Hazel, because if you're talking, when you're talking about holistic services, are you suggesting not specifically new therapies, but
No, yeah, so she's
new services? Yeah,
put in like dietitians, for example.
Yeah. So I think that there's a need to provide a more holistic approach to care. And I think that's recognised by NHS England and by the regional integrated care networks. And I think that there is a kind of general agreement also that the model that's just based on the hospital doesn't capture everything, and it kind of focuses on, just when you're acutely unwell with a pain press or whatever. But if you're providing holistic care over, a lifetime, and with all the aspects of the way that the condition can affect life and opportunities and function and so forth, then there are a lot of different support specialists and non-specialists that need to be accessed, and they need to be accessed really from the community rather than from the hospital. And what's happened recently is that I think that's been recognised by NHS England, and it's come along at the same time as these integrated care boards have sort of come into existence, whereby specialist care is being delivered more holistically, combining the hospital and the community. It's not just for sickle cell, but for other conditions as well. But within sickle cell, and probably partly related to the response to the all-party parliamentary report, there has been some extra investment or channeling of money towards developing this kind of holistic care with more emphasis on the community in London. And so that we have basically been working together with our colleagues across East London in the sickle hospital and community setting, as well as the kind of commissioners in North East London, to put this together. And patients are involved in the discussions. There's still a lot of work to be done, but I think the main point is there is some more investment now, and that should help, for instance, with psychology services, possibly with social work, and with access to more community-based services that previously were not so accessible. So that's, I think, I'm hoping that will make a change, will make a difference. It will take time to kind of get it right and to bed down into the rest of the healthcare network environment.
Brilliant, thank you, Professor Telfer. Yeah, I don't know if anyone else has any questions for either Professor Telfer and Dr. Greaves?
I've got a point. I don't know if it's a question or just I don't know what it is actually. So if we start using more plasma, for example, if it takes off and it's wonderful, how will that affect things like blood transfusions or not blood transfusions, sorry, blood donations? Because at the moment I'm a blood donor, so I give blood. But are they going to now need different people for blood transfusions? I mean, will it still be the same blood and then they do all the whatever, or will they need other people? I don't know what I'm trying to. I'm not phrasing it
I
properly,
think
but
there's always a requirement for more blood donors, particularly more blood donors from minority ethnic groups, because of the association of some blood types with sickle cell disease, and therefore we'd always encourage more people to become blood donors. The first thing. I don't think plasma exchange though is going to put an much additional, this might be wrong, much additional burden on the transfusion service to the same extent as red cells. When you donate red cells, often it's fractionated into, or you donate whole blood and it's fractionated into the various bits you need. So plasma is taken off, platelets are taken off, red cells are separated out, and the kind of plasma you might need is different. But without speaking for the MBS and our National Blood Service, I'm not sure if Professor Telfer might be able to have more knowledge on this. The relatively low stocks are usually around plasma. They're usually around platelets and red cells. And we know we use an awful lot of red cells to maintain good exchange transfusion in people on a kind of rolling regular basis. So I think for emergencies, it's not going to put additional pressure on, but we should all be active in encouraging those that we know to become donors in any case. I think that's probably about the size of it in terms of resource. The main resource is people. To a certain extent, equipment, but people are the thing we need to retain, pay properly, recruit and train properly. And these are the difficult resource. We can buy as many exchange machines as we like, probably can retain a donor pool, but we need those trained personnel in place to make the decisions and to deliver the service. And I think that's the rate limiting step a lot of the time.
so in terms of plasma, can people donate plasma and then separately donate whole blood? Why I'm asking is this, because the reason I give blood is because I want to support my community who's in desperate need of blood. So what I want to know is, where will my blood be best served? Will it be through the plasma, or will it continue to be through the whole blood?
Most likely through whole blood donation. Plasma donors are very specific kind of person who can give on the kind of machine that just extracts plasma straight away. But beyond that, that's a very good question, and I'll take it away. But I would recommend that if you want to remain being a donor, the most effective way is to be a whole blood donor. But if there's a way of giving plasma when there might be a need for that, then certainly those donors do exist. But they're a very particular kind of unusual kind of donor with the best kinds of veins, because it requires the kind of machines that we do phoresis on and that sort of thing. So being a whole blood donor is probably adequate, more better. Yeah.
Amazing. Thank you. Has anyone else got any questions? Kai, I've shared your link in the chat. Okay.
Thank you, Hazel.
No worries. If no one else has any questions, I think that's it.
Has anybody got any questions or comments? Something that we can all take away with us this evening? No?
Okay.
So it's both Professor Telfer and Dr. Paul, thank you so much.
Yeah, thank you.
For your time. We really appreciate your time. I love that lamp behind you, Professor Telfer.
Yeah, that is
I don't know what it
amazing.
but it's really nice.
I'm actually sitting in my gym. Yeah, because I was kind of around and about this afternoon, and this is the only place I could find to be able to take part. But yeah,
it's nice.
but thank you for it is a nice lamp, isn't it?
Yeah.
Okay, sorry. Cheryl has one last question. She says, when will we see the service reinstated for pain management on the day unit? Funneling us into A&E is not functioning or conducting.
Not
not in capital letters, not functioning and conductive to the well-being of patients. Don't say it's from me. Okay, it's not from Too late.
Need to start with that bit.
Yeah.
Yeah, I think that's I think it would be quite good to have a session on pathways of pain management as well, because I mean, Demetrius deliberately didn't want to talk about these hyperacute units, and some of you might know that there has been some activity with NHS England to try to commission essentially what you're talking about, Cheryl. But it's a long story, and I think probably not for this evening. But so not to be flippant, but I agree that I think that an integral part of managing sickle cell, particularly in a large unit, is to have the availability of an ambulatory care unit that can act as a kind of bypass or a kind of to feed off from the ED. And as you know, we used to have this at the Royal London. It closed during COVID, and we've not, despite many attempts, we've not been able to get an agreement to get that restarted. And I think we need to discuss that on a separate occasion.
Okay.
But I do feel that this is something quite important to improve on.
Another question was, are the hyperacute units going to be attached to the hospital or separate clinics?
No, they will be. So the hyperacute units are basically a model of care that's been proposed by NHS England. It's not necessarily going to be something that sticks yet, and they're looking for some. They've basically commissioned some pilot units with very, very strict specifications that have to be met, and it's not clear how many of these units are actually going to be set up and funded at the moment. I'm not sure, but it will be a small number, and essentially they could be very good, but there are some challenges. And I think that one of the things is they would have to be in a hospital, because there are situations where you need a bit more than a hyperacute unit. You need a high dependency unit, you need an intensive care unit, and sometimes you need that very quickly. So I think there is a general agreement that these units would have to be in a hospital, but would be a unit separate from ED, and would be a place where people could get better treatment for pain without having to go through all the anguish of and difficulties of the emergency department pathway. So they're a good idea, but obviously you can't staff a 24-hour unit for this in every hospital in the country. And the resources that need to staff a 24-hour unit, even serving a region, are very considerable. And so anyway, there are quite a lot of issues around this. And I think it would have been probably nice to have had a bit more discussion with stakeholders in the planning of this, shall I say. But we'll see how it's developed. I'm sure there will be communications about it on the Sickle Cell Society website, NHS England and so forth, and various consultations along the way.
Thank you, Professor. Stefan has a question.
Yeah, I have a question. If I'm updated correctly, there's a concern that the junior doctor strikes could continue. And I was wondering if there's a plan to help the sickle cell patients that need to be admitted and go through A&E process, or is there advice you can give us on how to navigate a scenario where there's a lot of pressure on the staff that are not on strike and have to deal with the added workload?
So speaking from my experience at Queen's Hospital, we found that with a lot of cancellation of regular work, the emergency side of things has operated reasonably well, with a lot of, as you've said, a lot of pressure on the more senior staff, but a lot of more rapid senior decision making in A&E. So we'd have to assess this properly by, as Dr. Telfer says, the service users, you guys, who had to come in and say, how was it this time and how has it been when there were junior doctors? Not to say that the junior doctors get in the way of care or that junior doctors, without them, it doesn't function. I think we find it functions differently. And I think we're learning ways around how we should be offering more senior specialised review at the front door in the acute areas. So really, I think this is enabling us to test a different system of care where the specialist comes more rapidly to the emergency department, and perhaps that's to the benefit. But so much has to be cancelled and set aside to make that work. And that puts so much pressure on the more members of staff that I think we'll find that's not sustainable. So the bottom line is the industrial action and the dispute has to be found a way out of, which is a much bigger issue than this. But in brief, I don't believe from my experience locally and local immediate feedback that there's been any compromise to the normal routes of access of care. You've still got the nurse specialists, you've still got the consultants at work for emergency care. And that would include consultant strike when it's not emergency care that's being withdrawn, it's elective care. And that's where we might see the problems.
Thank you. Stella, you've got your hand up.
Yes, just a quick question about the therapeutic plasma exchange. The study that was done or that is being done. Which hospital or trust is doing this, and is this information available for my doctor to access, for instance?
Stella, I can answer. So I think this is quite an early stage in the development and kind of looking at this form of treatment, and it's an early stage of a clinical study or a series of clinical studies that we're talking about. And what Dr. Demetrius described is this protocol in 3 hospitals. So the Homerton, Royal London and Queen's. So it's an East London based study. It's just going to be a very small number of people, about 15, with a specific complication, i.e. what we call the acute chest syndrome, who would be evaluated having this extra procedure called plasma exchange. So we're at a very early stage in this process at the moment. And if that is shown to be successful, then that evidence to go on and do the next stage and gradually kind of building up, and but to get to the stage of actually implementing into sort of standard care in the health service takes a long time, and that's the way things have to be done.
Thank you. When you say a long time, do you mean like 10 years or 2 years? If you say early stage, how long is the first?
So it would depend on the circumstances in which you are using it. So, for instance, if you're talking about a very, very severe complication like fat embolism or severe acute, where somebody is not doing well, even having had exchange transfusion, and there is evidence, for instance, from this study that plasma exchange helps, then I think that would be something that could be used more widely based on that quite early evidence. But if this was going to become a kind of treatment to be recommended much more generally, maybe to prevent complications of sickle cell, to use routinely when somebody comes in a painful crisis, the resource implications are much more because there are many more events. You need more personnel, you need more equipment, you need more blood to do that, and so you really got to show that it does add something. And that's the way that it works in sort of developing new treatments. And our health service that you've got to go through all these stages, and it's partly because you've got to show that it's effective, that it's safe, that it's value for money, because the NHS has a finite source of money, and if you're spending a vast amount of money on something which doesn't make a huge amount of difference, then some people are not going to get treatment that that would be where money would be otherwise used. So all of these are quite important decisions, and it's not to say that that it's not important to find new treatments for sickle cell, but we have to go through this process in a sort of systematic fashion.
Thank you.
Yeah. We've got a question from Shane.
Hi, Doctor and Professor. I was just wondering, the two of you, is there any way to make contact with you regarding anything that's come up today or with sickle cell in general, like emails or?
Certainly happy to receive questions. There's a sickle cell and thalassemia email address that's monitored daily at VHRUT at Queen's, which we can share. Perhaps, I don't know if there's a shared forum that we can put that to and then back to the group.
Yeah,
And that certainly could be checked into. Yeah, you're very welcome to use. That's probably the best way. There we go. Thank you, Becky. Right on track.
Amazing.
Thank you very much.
We've got 2 WhatsApp groups, we put them in there.
Fabulous.
Yeah, but I think Shane, there might be something maybe for Hazel and Solace to think about, some kind of regional wide kind of I don't know, communication system to for answering more kind of questions about sickle cell, new treatments and so forth.
Yeah.
I mean, if it's a specific thing about your treatment and how you might benefit from new treatment, then that should probably go through your own clinic and your own doctor. But more general questions, yeah.
Yeah.
All right, thank you.
Yeah, definitely. We can look into that. But thank you very much, Professor Telfer and Dr. Greaves.
Thank you.
Thank you. Awesome. Cool.
Thank you, Professor Telfer. Don't do.
Thanks.
All right.
Have a nice evening, everyone.
Thank you.
See you later, everyone.
Thank you to both
Bye,
doctors.
everyone.
Thank you very much, Oleander. Thank you, everyone.
Thanks, everyone.
Thanks, everyone.
Thank
Thank you.
Yeah,
Bye.
for your evening.
All right.
This is for general